Hi, everybody. Thank you so much for joining us tonight. On behalf of the Wisconsin Academy, I want to thank you for taking time out of your schedule for our second After Office Hours webinar. Like Joy said, my name is Carl Pradell, and I'm the Manager of Strategic Initiatives at the Wisconsin Academy of Family Physicians. One of these initiatives is called E3, designed to engage, enrich, and energize. The E3 offering includes live webinars, road shows, meetings, ceremonies, and other events. I'll be moderating the webinar tonight, Family Medicine for America's Health, Transforming the Specialty and the System to Make Health Primary. Now, before I introduce tonight's presenter, I wanted to just go over a couple of housekeeping items for everybody. The first is on CME credits. Just to let everybody know, if you're interested in CME, in order to receive your CME credit, you must complete the evaluation after the webinar. The link for the evaluation will be sent to your email address right after we complete tonight's presentation. If you don't receive the link, please contact the Academy at 262-512-0606, or you can email us at academy@wafp.org. And then the second item that I wanted to just go over is the WAFP Foundation's 2015 Summer Externship Program. So the Foundation is looking for enthusiastic preceptors interested in mentoring one or two med students for 1 week in the summer of 2015, next summer. For more information, you just need to contact the Foundation at the same number I listed before, which is 262-512-0606, or visit the Foundation online at wafpfoundation.org. And if you can't volunteer your time next summer, there is another way that you can help with the program. You can consider supporting the students with a donation, and you can find information on how to donate at wafpfoundation.org/donate. So now that I've taken care of those couple of housekeeping items, and in an effort to keep things moving on schedule, I'd like to now introduce tonight's presenter, Dr. Glen Stream. Dr. Stream is past president of the American Academy of Family Physicians and now serves as board chair of Family Medicine for America's Health. Dr. Stream practiced in Eastern Washington before recently relocating to Eisenhower Medical Center in Rancho Mirage, California, where he is Ambulatory Chief Medical Information Officer in addition to seeing patients. And with that, it is my great pleasure to introduce tonight's speaker, Dr. Glen Stream.
Well, thank you, Carl, for that introduction, and thank you, everyone, for joining. It's difficult to compete with the World Series, but we'll try to make this interesting and get us back to watching the game. So thank you for being here. It's really my privilege to have the opportunity to discuss this new project that has just recently kicked off. I'd like to give you some of the background behind that, a little bit about who's involved and what's being planned, and then how you can be involved and how we're open to your input as this project proceeds. So I'm going to see if my slide advancer works. I'm going to have to click right there. So Family Medicine for America's Health is the name that was given to the project that came out of the last 18 months of what during the time was called Future of Family Medicine 2.0. And the idea was to take this opportunity 10 years out from the publication of the original Future of Family Medicine report to sort of get the lay of the land. How far have we come towards our goals? What have changed in the way of environmental issues during that time? And where do we go from here? Very timely for this to happen, given the changes happening in our healthcare system, with 2014 being such an important year in the implementation of the Affordable Care Act and the highlight on the need for adequate primary care foundation to care for these newly insured folks. It just really made a great opportunity to do this. So the idea of the discussions over the past 18 months or so has not been at all to redo the work of the Future of Family Medicine, but simply to build on that and to redirect, and in many ways to learn from, what were we not successful in accomplishing that we had hoped to. So two main areas in that. One is that we still struggle in the public, people understanding the specialty of family medicine, the scope and breadth of our training, what services we can provide, and therefore what important value and services we bring to the healthcare system. And then the other is really fixing the broken payment system, the payment system that does not adequately cover payment for services in the primary care space, and really does not recognize the increasing intensity and complexity of the work that we all do every day. So we really wanted to have this current effort focused on achieving those areas. And then the other area that was different is that in the original Future of Family Medicine effort, at that time 7 participating organizations really divvied up the work of the tactics and tasks to be done. And the concern was that it would be more effective if we actually built an enduring structure during the time of the project. And so our current project, and I'll be talking in some detail, but a communications project anticipated to be a 3-year effort and a strategic effort for 5 years. That's the period of time we envision this Future of Family Medicine, the Family Medicine for America's Health structure persisting. So this slide depicts the 8 organizations that are involved in this effort. The addition since the original Future of Family Medicine project is the ACOFP, our osteopathic family medicine colleagues, and in their joining, it really brings increased strength to our coalition, and very much have appreciated their participation. So these 8 family medicine organizations have come together to create Family Medicine for America's Health. Each of these organizations provided a member to our Family Medicine for America's Health Board of Directors, and then we sought out 4 additional board members to make sure that we had adequate representation of the necessary voices for our success. We have an early career physician to make sure that that perspective is adequately presented. We have a solo, rural, full-scope family physician on our board to make sure that perspective is adequately represented. We have one of our chapter executives, Vince Keenan, who's the chapter exec in Illinois, is a member of our board, recognizing the important value that our chapters have in really getting the work done, connecting to our colleagues in the states and in communities where these efforts are going to happen to maintain that connection. And then the last is that there's a very significant focus on truly having a patient-centered perspective to these efforts. And so we have a patient advocate representative, Lauren Kennedy, who is the advocacy director for the National Partnership for Women and Families, who's a participant in our board. So those are the 12 members of our board. These organizations collectively have committed over $20 million to this effort over the next 5 years, which seems like a lot of money, except when you get into an advertising campaign and communication effort that this will involve. And so a lot of our work will not be in paid advertising, but in what's called earned media, interviews and op-eds and those sorts of opportunities, and all the digital communication channels that we have through these organizations, through our chapters, through social media to really get our message out to stakeholders. And to create a structure and get up and running quickly, it was decided rather than create a new entity that this organization would be set up as a limited liability corporation within the AAFP, very similar to how TransferMed is currently organized, and this board serves as the board of that LLC. The American Academy of Family Physicians and the AAFP Foundation collectively are providing the administrative services to support this group so that we're not having to pay our precious resources to get that administrative work done, and greatly appreciate their effort. But despite this being housed within the AAFP and the services provided by the AAFP and the Foundation, this is collectively an effort of the family medicine family. It's all of these organizations, all of its members and diplomats coming together to succeed in the strategy and communication that I'm going to outline for you. So these next couple of slides, I realize, are obvious to all of those working in healthcare and understanding some of the deficiencies in our healthcare system. America spends substantially more per capita than any first world country on healthcare, and yet truly suffers in the health status of our people. And it's a tremendous waste in many ways of those resources that they don't result in better health. It has economic consequences to our country in productivity and employment, and really pursuing improved health is the important focus that we're set out to achieve. You also know how imbalanced our healthcare delivery system is, more towards treatment and late illness care as opposed to primary prevention and wellness, good early chronic illness management that prevents those preventable expenses. And estimates show that only 3% of our healthcare spending is directly tied to prevention and public health, and yet we spend 75% of our healthcare dollars treating what could have been preventable disease. As a system, as I read this slide, it caught me a little off guard because these were prepared for me. As individual physicians, I don't believe for a minute that we've lost our focus on patients. But as a system, our healthcare system is not very patient-centered and does not support the coordinated, integrated care that we know we want to give to our patients. And an effort to improve that is very much at the core of this Family Medicine for America's Health effort, to invest in family medicine and the primary care infrastructure of our healthcare system so that we do have this patient-centered, health and wellness-focused healthcare system. In the discussions over the time that this effort was being prepared, there was a great recognition of the alignment with what we hope to accomplish and what has been called the triple aim. So the triple aim concept came out of Don Berwick and the Institute for Healthcare Improvement, and the concept being that we in our healthcare system need to deliver better care, safer, more patient-centered, higher quality care. We need to focus on improving health, the true health status, not just reducing mortality, but the health status of our people. And at the same time, we need to lower costs. The excessive cost in our healthcare system is a tremendous strain, not just on government, but on employers and on individuals. Number one cause of personal bankruptcy is healthcare-related debt, and over half of those people have health insurance. It's the cost in excess of their coverage that's still pushing them to bankruptcy. An important focus, really, in the conduct of this campaign is what's often been called the quadruple aim, and that is adding the measure of professional satisfaction to physicians, but also to other members of our healthcare team. All of you know the stress of daily practice, and it's often just made that much more aggravating by the intrusions of government and health plans and all the administrivia that we need to try to comply with. And we need to align our efforts, not just at this triple aim about better health and better health care and lower costs, but actually to have a system that all of us are more professionally satisfied in which to work. So Family Medicine for America's Health, again, is this effort, a broad-based strategic effort with several areas of focus, and I'll spend a couple slides talking about that. We want to expand access to the patient-centered medical home. We really believe in this team-based model of care. I'll talk in a minute about it's certainly an area where there's area for improvement, but we need to expand access and improve on the model itself over time. We very much have an interest in promoting technology in the delivery of health care. I think many of us have observed that the addition in some ways of technology has not always improved our engagement with our patients, and that's certainly less than ideal. So in the technology space, family medicine wants to be a convener amongst not just ourselves, but our colleagues in other specialties and in other healthcare disciplines as a unified voice in how can we feedback to vendors of health information systems, and most especially electronic health records, to make them more usable, make them an addition to rather than a distraction from our work with our patients. And then the other area of focus in technology really is in the really exploding space of patient-facing technology. I'm sure your patients do like mine. They bring in their blood sugar or their activity information on a smartphone app that they want to show me what's been accomplished. And more of our patients are using wearable technology. I won't give an endorsement to any particular brand, but I wear a wearable device that tracks my steps and allows me to track my health and wellness behavior, and I find it very helpful. But for the most part, it doesn't connect to my source of medical care. So how can we have this technology that's exploding in use amongst our patients actually promote their health and their engagement with us without overwhelming us with more information in a way that is not really practical? So we need to collaborate with the technology sector to advance those aspects of technology that, again, enhance rather than detract from patient care. One step that'll be happening soon is I and another member of our board will be participating in the Consumer Electronics Show in Las Vegas in January. If you're familiar with this show at all, it's the leading technology consumer-facing conference. It's where all the cool Xbox and things like that get unveiled each year, and we want to open up the dialogue with that technology sector to give some input and direction from the physician perspective about how do we work together to have technology that is not just commercially successful, but actually can contribute to people's health. And maybe we can have a process by which some of these technologies are evaluated in an objective way that can provide useful information to us on behalf of our patients and to our patients directly about, which of these applications are worth their time and money to investigate. We certainly need to do a lot to ensure an adequate primary care workforce, and I'll talk about that in a bit more. And I'll emphasize this last bullet point several times. We need to fix the payment system that provides the revenue to our practices to deliver care. We are convinced that fee-for-service is not that model. If you think about it, if you're having a limited service of some kind, you're having a surgical procedure, you're having stent placed, any of those types of things lend themselves to this idea of global payment, because you can bundle up all of the surgical and preoperative and postoperative costs. But for the care you and I deliver every day to our patients, the unit of delivery is a month or a year of care, and having a fair but also adequate and predictable payment model is absolutely what's necessary to support the care that we want to provide to our patients in this medical home environment. So the concept of this effort was to create a strategic plan. We worked with an outside consultant, very expert in this area, to develop a strategic plan for the Family Medicine for America's Health effort, but also to guide the strategic efforts of the 8 participating organizations. The idea is very much that there be some independence and autonomy for the strategic project, but obviously a lot of the work is done by these other organizations, many of which, many of us belong to more than one of them. So the idea, again, aligning our efforts with the triple aim, recognizing that any effort to achieve the triple aim is going to advantage family medicine and primary care. You simply cannot have a system that is delivering better care, delivering better health, and saving costs without investing in primary care. So the strategic plan itself has 7 core strategy with some implementation tactics that are in 6 different implementation areas, and I'll show you those in a moment. But we also recognize that we can't do this alone, nor in many ways should we try to do this alone. We're trying to change a very large, complex healthcare system, and there are many stakeholders in it. And we need to work with our colleagues, again, in other specialties, in other primary care disciplines, in other health professions, but also with health plans and employers and patient stakeholder groups to really collectively figure out how can we remodel our healthcare system with this strong family medicine primary care foundation to achieve these triple aim goals. So I would just bring to your attention this article that was published last week. So this is in the Annals of Family Medicine. It's a supplement edition and is available at that URL. If you just go to the Annals website, you could find it there prominently. But this is the report from the project itself regarding the efforts of the last 18 months, putting this project together, both the strategic and the communication strategies. And it's interesting, I don't have a lot of time to drill down into the research data behind this, but extensive research was done to inform the development of this project. And it relates to the perception of family medicine in the public and in health plans, government, subspecialties. And that result was rather striking, and that is that family medicine as a specialty is extraordinarily highly regarded. Our consultants doing this work were actually, I think, truly stunned to find out. These are those sort of public perception surveys where Congress gets down at 8%, and we're up in the stratosphere with the American Red Cross as a specialty. I would encourage you, when you have the time, to read through some of the research that's outlined there that guides the strategy that we're developing. So these are the 7 core strategies, and some of these I've touched on before, but I'll go through them briefly. The concept of the public education campaign is to show the value and benefits of primary care, the importance that we bring to prevention and wellness, to good chronic illness management, to the patient engagement aspect of healthcare delivery that really no other specialty does it as well and as comprehensively as we do. Our goal is that every person would have a relationship with a primary care physician. Obviously, our preference would be that that's a family physician, but in that medical home, team-based environment. Again, the idea of aligning these efforts with the triple aim, recognizing that that is truly a tectonic movement in our healthcare system, advocated by government and employers and health plans and in many ways patient advocates, improving the quality and cost aspect. This is very much in alignment with our goals and works to our advantage. We want to work to reduce healthcare disparities. As family physicians, if we're truly about health, we can't just be about healthcare. We have to be about those social determinants of health that so much impact the health of our patients. Education, environmental things like clean air, clean water, education, and then especially an area of personal health behavior where we can hopefully be a positive influence is in those health behaviors like alcohol and drugs and tobacco and risky sexual behavior that compromise the health of our patients. The idea of leading the continued evolution of the patient-centered medical home is to recognize, although there's good evidence for its efficacy, that there's no system that's perfect. Some of our colleagues are still skeptical of this model, and my interest is to embrace their skepticism and ask, what aspects do you find problems with? How can we address those? And not to throw out the concept, but rather to evolve it, and very much based on data, doing healthcare delivery research that shows the improved health outcomes and the cost savings that we know we can achieve through this model. The concept of a well-trained workforce goes across the entire pipeline of producing and maintaining primary care physicians, all the way from getting interested applicants into medical school that have that aptitude and interest into medical school, not having their medical education experience snuff that interest out, dealing with their educational debt, providing strong and adequate capacity in residency training programs, and then very much just as important is, again, delivering that professional lifestyle satisfaction that makes people want to continue practice rather than face burnout issues. And then again, I'll emphasize this idea of moving away from fee-for-service payment towards a comprehensive primary care payment strategy that adequately compensates for the intensity and complexity of modern primary care. So the idea here is not a risk payment, it's not capitation, but the idea that a bulk of the payment for primary care services is paid for a global range of services. Some things are still paid for by fee-for-service because we don't want to disincent them by having them in the global payment. So continuing to do hospital services, continuing to do obstetrical and ER services, some minor office and major office procedures are things that you should still get paid for your work because it costs the system more if you send them out of your practice. So we want you to be paid for those. But again, I'll just emphasize, fixing the payment is a linchpin component of this effort. So these are the 6 tactic areas, and a core tactic team has been identified for each of these. And there's a lot of the tactics that cross over. For example, one that I like to highlight is if we're able to move towards this comprehensive payment system and away from fee-for-service, maybe our interaction with our electronic health record could be more about delivering good care to our patients rather than capturing the necessary information to get paid appropriately in the fee-for-service coding system. How nice would it be if we didn't have to focus on that aspect and we only used it for documenting care and improving quality? So that goes between payment and technology, simply as an example. Obviously, between the payment model or the practice delivery model of the PCMH, a research component to those. So a lot of crossover between these. This is one area, and I'll highlight this towards the end as well. This is one area where if you're so inclined and have interest and expertise to offer, each of these tactic teams will have an extended network built around them where you don't have to show up for face-to-face meetings, but you have an opportunity to provide your input and perspective directly to the work effort that's coming from these projects. So look for that opportunity, and I'll mention that in a minute. So this is the patient-facing communication strategy that was unveiled last Thursday at a press conference in Washington, D.C. I've mentioned the alignment with the Triple Aim, and we were very grateful to have Don Berwick, who's really the father of that concept, speak at our press conference in support of our effort. He was very supportive of the concepts we're working towards, but also very challenging in his remarks that we're the right people and at the right time, but we don't have a lot of time to get this done, that we need to work with others to accomplish it, and that we need to put patients at the center. And then the other person who spoke at our press conference was T.R. Reid. You might be familiar with his book, Healing of America, that was published in 2009 and got a lot of highlight during the healthcare reform debate. But it's based on his experience as a writer living in different parts of the world and experiencing their healthcare system and providing insights about how our healthcare system might work better. So it was a good success. Obviously, it's just the beginning of rolling out this messaging campaign to patients, and I'll talk about that a little bit more in just a moment as well. So at that event, we released a video, and the next slide is to show you that video. It's just about 2 minutes.
When we were growing up, medicine meant our family doctor. When we were sick, had a broken bone, or got hurt, that's where we went. The technology was simpler then, but our doctors took care of us and helped us stay healthy. Things changed over time. We changed, and healthcare started to change too. Scientific advancements made medicines and treatment better, but the healthcare system got more complicated. We started spending a lot more money, but all that investment didn't make people healthier. Healthcare started to feel a little disjointed and impersonal. Now everybody is talking about reform and the system. It's gotten pretty loud, but nobody's really talking about health, good health. Isn't that really what we all want? Our country has the best doctors, the best hospitals, and the most innovative scientists. Shouldn't we be healthy? Somewhere we lost our way. We forgot what matters. We need to embrace the values that make people healthy, like a long-term relationship with a trusted doctor, someone who knows us, our family, and our risk factors, someone we can connect with when we need them, who uses the latest technology, someone who can help us stay healthy, and when we're sick, help us get the most from the healthcare system, someone who can see the big picture and the small one. That's what the best healthcare should be, a system based on primary care that can make our advanced medical system work for real people. We know how to get there, and going there now can give us a system that works for everyone and makes us healthy again. Now is the time. Together, let's make America a place where health is primary.
So that's the beginning of our patient-facing communication and media strategy, and the idea is to use those messages and others as time goes out in a couple of different ways. So the idea of the patient outreach is that we provided to each of the chapters a toolkit for messaging that can go out to the members in your area. And we want to focus over the next coming year, and I'll show you sort of an outline of a schedule, and reach out to patients about important health issues from the perspective of family medicine and the importance of their working with their personal physician to improve their health. And some of the initial topics will be around tobacco, nutrition, fitness, immunizations, and the importance of chronic disease management, especially the kind you and I do, where it's often patients with multiple chronic illnesses. The idea of the community engagement is to go on the road and to do city tours, to highlight in communities efforts of physicians coming together with patients and health plans and employers and public health, whatever the stakeholders might be for that community and the issue in which they're dealing with, about how they work together to improve health. Because we know that there's areas around the country that are doing this well, and we want to highlight those, highlight the role that family medicine has in them, and hold them up as examples to what other communities can accomplish, and show them the tools and the path to get there. And again, this idea of a focus on technology, not that we're going to write and release software by any means, but to be a voice to represent the frustration from physicians and the confusion from patients about how does this tool of technology have the potential to improve our health. These are some of the ads that are part of the Health is Primary campaign, again, focusing on innovation, the idea of that personal relationship, everybody knows your name, the focus on prevention, the connecting the dots, that idea that a patient is not the sum of their individual organs, but that they are a whole person. This get more FaceTime with your doctor, again, sort of a play on the technology, leveraging remote technology, that everybody wins, the patient and the system, if the healthcare system is more primary care founded, and the team-based concept that we work best when we work with our colleagues in other disciplines focused on the best healthcare for our patients. So again, some more materials just aligning with the triple aim concept, with the information to patients to really frame it. You know, one primary care physician per 100,000 people has these benefits of reducing outpatient visits, ER visits, admissions, and even surgeries just by the good primary care that we can deliver to them. So this is the schedule for what's coming out. The national campaign launched just last week. The city tours anticipate rolling out beginning in January or so. The mini campaigns as well with these individual areas of health focus. So some overlap between those, but stay tuned. More to follow on those campaigns. Plans are just in the process. So I mentioned the opportunity to follow and stay connected to this effort. So the Twitter handle is at Health is Primary. There's a Facebook page for the effort. The healthisprimary.org website is primarily the patient-facing information source, and then the FMAHealth.org is really the strategic effort. That part may be the one you're most interested in, is, you know, what's going on with this campaign, how can I contribute, and what are they working to do on my behalf to improve the healthcare system where I work. So, and then the other engagement opportunity, there's an email Dropbox at that FMAHealth.org website. It's just info@FMAHealth.org, FMAHealth.org. And your suggestions, your feedback, your comments, your constructive criticism is all welcome. And it'll come into a Dropbox and be distributed to me or other members of our team to incorporate into our efforts and to respond to you. If you're interested in that network component of the tactic team work, you could send an email to this email Dropbox, express that interest, you know, which area you're interested in, what your background is to contribute, and if you're so inclined, I would really encourage you to do that. So with that, I'd like to use our remaining time to take any questions and hear from you about your thoughts about the campaign, how we could do better, and how we can work together to make Health is Primary. So with that, I'll turn it back to you, Joy.
Thank you, Dr. Stream. To ask a question via phone, press *# on your telephone keypad now. As a reminder, text chat is located on the right-hand side of your screen. To submit a question, type your question into the small text box at the bottom, and when finished, click the Send button. Please note that due to time constraints, our panel may not be able to respond to all questions submitted. And Dr. Stream, it does look like we have a phone question.
Yes.
All right.
Hear me?
All right. Psych, go ahead with your question.
I'm sorry, Glenn, you can't hear me?
Yeah, I can hear you, Alan.
Okay. The last one of these we had, I remember you asking the group, and I think it was a national group, about what the basic skill set a family doctor should have, so that we could more clearly define what a family doctor is. Has the FFM group and FMAH come closer to a definition of that, of the basics, and what might be added on to that by people who want to, maybe not by others?
Yeah, great question, Alan. So, part of this whole campaign is, we want to get the message out to folks, but we also have to be able to deliver on that, and to avoid unmet expectations, we need some agreement about what it is we as family physicians are trained and prepared and capable of doing. So the concept that's evolved in professions is this concept of entrustable professional activities, or EPAs. Yeah, you might have read that the Association of American Medical Colleges just put out 2 weeks ago, I think, EPAs for what we should expect of graduating medical students, what their capabilities ought to be on their first day, starting as a first-year postgraduate trainee. And so very much that concept has been in discussion as part of our efforts. It's in its third or fourth draft iteration, and I anticipate that it would be released maybe by December and it's sort of broad areas as opposed to a menu list of what should be done. But I think you'll find it very much continues to incorporate the concept that we should be trained broadly, continue the capability to do obstetrical and hospital care, and that we need to train family physicians so that they can go out and meet the needs of the community in which they choose to practice based on what those needs are. So they may need somebody to deliver babies and do hospital care, maybe they don't, but the training of the family physician should allow them to do that. So stay tuned, that should be out relatively soon. I'm guessing by end of the year, January at the latest.
Great. It looks like we have some other questions here, Dr. Stream. Scott Peschke says, I agree with the concept, but when will the payers start adequate reimbursements for the time and effort it takes to create and maintain a PCMH? Yeah,
I can't give you a date, but I can't emphasize enough the level of commitment across these several 100,000 physicians, if you look at the membership of each of these organizations, that the status quo simply is not acceptable. So the challenge is, we are not able to collectively advocate for X amount of payment, antitrust sort of things. The other thing is a lot of the issue is actually with the current payment model and how it alone discounts the value of primary care. So the concept is we need to do something that's truly revolutionary, and that is to not just pay better for primary care, but to pay differently. This idea of a large comprehensive care payment that's a per member per month, again, not a risk payment and not at risk for their total cost of care, but simply their primary care delivery, which most health plans will tell you is about 6%. That's what it is for Medicare. About 6% of their healthcare dollars spent on primary care. If they increase that by a third, you can't tell me that you and I, with the efforts that we could bring to bear with better coordinated care, better prevention and wellness, save that on the back end of saving unnecessary care that doesn't really contribute to people's health. The Commonwealth Foundation published a study about the effect of the Medicare primary care incentive payment, that 10% bonus payment. And their study, independent entity, obviously not a family medicine organization, their assessment was that 10% investment had a six-fold return in global savings. So the understanding of how we need to change the payment, not just to advantage family physician income, but to improve the healthcare system is I believe, at the tipping point of catching on, and we absolutely just need to take advantage of that.
Okay, thank you very much. Let's see. David DC asks, why is it that after 40 years, family medicine is still a well-kept secret? What could have been done better, and how will this initiative be different than what we saw in the past?
Yeah, I'm not sure what could have been done differently. I'm a look forward, not look back person, but I'll tell you, I just relocated after 22 years practicing in the same community, and people that I'd taken care of for that 20 plus years, you know, I told them about my involvement in family medicine, and I'd been president, and they go, family medicine, what's that? And I think you're exactly right. Our patients don't necessarily understand who we are and what we do. And the purpose of this extended communication effort is to do better this time on that. We've never had this length of time, this in-depth, and this well-financed of a communication and, for lack of a better word, branding effort, again, not just to the public, but to government and payers. The other thing that's really different is that this window of opportunity is unique. Regardless of what people think of the ACA or other healthcare reform efforts, that debate has really shined a light on the value of family medicine. People who did not understand the importance of good primary care to cost-efficient, high-quality care, and did not previously understand the challenges that we face in payment and workforce, they get it now, and we're going to monopolize on that.
Fantastic. Let's see. David Deasy also says here, whoop, I lost the question, pardon me. Here we go. The public campaign ads highlight health is primary, but America's Family Physicians is in much smaller print. Are you concerned that it dilutes the branding of family medicine?
So the idea of the campaign, and all I can tell you is we've engaged basically an international branding and communication company that's guided and developed the creative thought behind this. The idea is that we really need to be about health and about patients, and that the carry-along message about that is that family medicine is the way to get there. So the idea is that it's brought to you by America's Family Physicians, and that gets rolled out over time. The concept, too, is this idea of health as primary care is an intentional play on words that we very much will be taking advantage of as time goes on. But I would not take the font size in these messages as where the importance is, because it's not. It really is about family medicine stepping up to promote health in our country.
Wonderful. Thank you. Thank you, Dr. Stream. I actually have a question here. Being a marketing guy, with the consumer-facing Health is Primary campaign launch, what are we hoping the consumer will do? It seems to me that primary care physicians are going to need to be really dialed into this campaign so that when these patients begin to engage the physician in conversations that are naturally piggybacking off the Health is Primary campaign, they will be ready for that dialogue. And so I'm just curious on that kind of that part of the equation.
Sure, great point. You know, I would say that the things we're going to highlight in these health-oriented campaigns, highlighting the role of family physicians, the idea of tobacco cessation, about immunizations, health and wellness, chronic illness management. These are the things that we do every day, and I don't think that part will be difficult to engage our patients in their questions, even if their physician had not even seen one of these ads. What I would say about the patient engagement piece is we very much are going to encourage practices to have a feedback mechanism from their patients. So if it's a small practice, it might literally be one person. In a larger practice, it might be a small committee. But the idea is if we're going to be patient-centered, we need to hear from our patients, how are we doing? And it's not just what happens with the patient and physician in the exam room, whether they feel respected and listened to, but literally is the scheduling and the billing system. Can they get in when they need to? Can they get parking? You know, those things that are part of the health delivery that actually significantly affect patient satisfaction. And the goal there is to have patients so engaged in their primary care that they become our advocates. We want to mobilize patients so that they're the ones going to their health plan or their employer or advocating with their government and saying, I want you to invest more in primary care because I value my doctor, I value the care that they give me, and the system is disadvantaging them, and you need to fix it. So the idea of mobilizing patients as our advocates is something we have tried at different times in the past. Probably the best example is trying to mobilize our patients about fixing the SGR, and oh, by the way, here we are again with the SGR. But that's more about us than about them. And the idea here is if patients truly understand the importance of primary care to their health, that they will be our advocates and our allies as we advocate for the system changes that we need.
Well, that's wonderful. That's exactly kind of what I was interested in hearing. So that's really exciting, and certainly, you know, we want these dialogues to be dynamic with the patients. So wonderful. Let's see. Larry Pfeiffer, our executive director, is asking a wonderful question. What is the opportunity for students and residents to engage in this effort?
Yeah, that's a great question, Larry. Thank you. So, you know, very much an opportunity to give input and participate even in these extended tactic team networks, you know, particularly around the workforce aspect for our folks that are in training, you know, their perspective about what are they seeing, what are the barriers, how can we overcome them, but you know, more broadly, to be engaged at the local level. One of the things that was highlighted at the press conference by both Dr. Berwick and T.R. Reed is that we're unlikely in our current national political climate to see some major initiative come out. You know, hopefully around payment as an exception, but globally, not going to see a big change. And so a lot of the efforts that we're promoting are going to be at the local level. And I would say the best first level of engagement for students is through their family medicine interest group at their medical school. But second is engagement with their chapter. You know, our chapters are going to be very essential and integral parts of this campaign, as evidenced by this webinar being provided by the Wisconsin chapter tonight, which I greatly appreciate. But engagement at that state level really is the first step. And then obviously as this campaign rolls out over the next few years, it'll have a major footprint at the larger conferences. So the annual conference for students and residents that's at the end of July, early August in Kansas City. There's an effort that's at the Society of Teachers of Family Medicine conference, their practice improvement conference that's in early December. I'll be speaking there, and there'll be engagement with the attendees. And I see this over the next few years as having a role at most of our meetings. You know, what's going on in this effort? How are we doing? How do we share experiences, and how do we, you know, over time improve the momentum behind this effort?
Fantastic. Well, thank you very much again, Dr. Stream. We're closing in here on 8 o'clock Central Time, so I just want to check and see if any of the participants have any additional questions. Okay. Well, then with that, I think we can wrap up for the evening. Again, well, hold on. I'm sorry. Dr. Schwartzstein asks, what can we do?
Boy, that's a broad question. So, I do think the following along on the, in fact, I'll go back a couple of slides, following along just to see what's going on in these efforts, because it may be that over time, different aspects of this initiative will appeal to people with different interests, with different previous experiences. So I definitely would stay tuned, through these communication channels. And then using this, the email Dropbox to send in suggestions or comments. And again, I'll highlight the opportunity, and you could express interest through that email Dropbox, potentially serving on one of the extended networks around one of these tactic teams to contribute more directly. Honestly, I think the best thing that all of us can do is continue to take good care of our patients every day, to focus on their health and wellness. When hopefully they'll be seeing these ads, and we can, involve them as our allies, moving this effort forward. If your practice doesn't already have some feedback mechanism from patients, I would encourage you to do that. A patient advisory committee or patient advisory role, because I think we'll be surprised what we hear from patients. Perhaps very easy things to fix that we just don't see because we're, in the grind day to day. But involving patients in their health and their healthcare delivery can only contribute to the success of family medicine.
All right, wonderful. Let's see. We've got one last question here from Larry Pfeiffer. So he asks, will there be 5 or 6 city tours in Wisconsin?
There'll be 6, Larry. We just need to talk about what that's going to, cost. So we can have a good conversation around that. But in all seriousness, the idea around the city tour is to highlight areas where there's been great success stories around broad-based efforts to improve the health of a community. And obviously, we want to highlight family medicine role in that. But again, recognizing that it takes major stakeholders and from various perspectives to have that large and sustained of an effort. Again, it's public health, it's employers, it's health plans, it's government, all of those. So we're looking for those good stories. If you have a good story to share, you can send it to me or to that email Dropbox. It's a 3-year campaign, so there's certainly an opportunity to get in there somewhere. And we're just looking for compelling stories and strong partners to tell them.
Fantastic. Okay, well, thank you so much, Dr. Stream. A very exciting presentation and campaign, and certainly excited to see the forward progress moving forward. Just a reminder to folks, again, regarding CME, you'll be getting a very brief survey after we wrap up here, and in order to get your CME credit, you do need to fill out that evaluation. We ask that all participants fill out that evaluation regardless. It's a great help to us to see how we're doing and to see areas that we can make improvements in the future. So with that, I think we will close. We're just after the 8 o'clock hour. So thank you all for attending, and you can now go and enjoy the game. And again, Dr. Stream, thank you very, very much.
Great. No, thank you, Carl, and thanks everyone for joining. Good night.
Good night, everybody.